So this is a structured Viva task assessing information gathering, communication with patient, communication with colleagues, patient safety and applied clinical knowledge. You are the registrar on call. You have been called to assess a 31-year-old patient in A&E who presented with fever, shivering, lower abdominal pain, abnormal smelly vaginal discharge. Recently, she has started a new relationship. The examiner will discuss with you regarding further management. So from the station, it looks like a patient with PID. However, we still have some differential diagnosis. We need to rule out some conditions. So usually the first question from the examiner will be what data from the history you need to know about this patient. So we'll take the history, first of all, her presenting complaints or presenting symptoms, she's having now fever, lower abdominal pain, and smelly vaginal discharge. We need to know since how long she has got these symptoms and whether, they appear for the first time or she had, this sometimes she may have this vaginal discharge for a long time, but she just mentioned it today and is not related to her condition. So we need to know whether all of these symptoms came together suddenly recently after her new relationship or no. Okay, so that's regarding her current complaint. Again, we need to take a full gynae history. So any gynae case, we need to stress on the gynae history. So the first thing of the gynae history is to ask about the menstruation. So when was her last menstrual cycle? Why we need to ask? It's very, very important because sometimes this patient may as a complication of early pregnancy, maybe she has septic abortion, or she may have ectopic pregnancy and she has a fever for another reason. Okay, so we need to know when was her last menstrual period and whether she's on any contraception, reliable contraception. Why we need to know about contraception? First of all, to be sure that she's protected from getting pregnant at this moment, so she's not having ectopic. However, we can't rule out that without doing a urine pregnancy test or beta HCG at least. Okay. Second thing that we need to know what type of contraception she's using, because if she is having a sexually transmitted infection and she is not using a barrier method, we need to advise her to use the condom even if she uses another method of contraception. The third reason to know about her contraception, because some patients may be using intrauterine device, so we need to decide whether we need to keep it or take it out if she is not improving. Okay, so the contraception is very important question here. You can ask tell the examiner that I need to know more about her periods, how regular it is and how heavy, because usually patients with PID sometimes they may get heavy periods. Also, we need to ask about her previous smear history, like if she's up to date with her smears, whether any previous infections in her pelvis, whether she has been diagnosed with any other sexually transmitted infection. What about her partner? He is a new partner? What about the previous one? And since how long they have been together? Because if she's having PID, we need to trace her partner in the previous 3 to 6 months. Okay. Whether she has any problems with the intercourse, whether this discharge is coming in relation to intercourse, or it's just there, whether she has any postcoital bleeding, whether she has any pain, severe pain, dyspareunia, because we need also to exclude endometriosis. Okay, so this is the gynae history. We need to take full obstetric history if she has ever been pregnant before, and whether she has any future fertility plans. That's because if she's having really PID, that can cause for her problems that may cause her to be subfertile because of the pelvic adhesion, and also sometimes tubo-ovarian abscess, hydrosalpinx, biosalpinx, putting her at risk of chronic pelvic pain and also ectopic pregnancy. So we need to know her future fertility plans, okay? Going down to the other items of the history, we need to rule out any allergies or hypersensitivity reactions, because usually these kind of patients need a long course of antibiotics, so we need to know about their allergies. We need also to know whether she has any other medical problems or other conditions, and also if she has any previous surgeries, if she has any family history of concern. What about her social history, smoking, alcohol, drugs, and what about her social support or support at home, okay? So that's from the history. Then the next question will be, what are the data from examination you need to know about or from this patient? So generally we need to take her observations, which are the vital signs. So we need to take her temperature, her blood pressure, her respiratory rate, and her pulse. So why the temperature is very important? In spite having fever, but the degree of temperature will give us an idea about the severity of the infection. And also if she has a temperature of 38 or more, she may need to be admitted to the hospital. And also if her temperature is at this level, we may need to do the full septic screening investigation for her, okay? So after the vital signs or observations, we need to examine her tummy, abdominal examination. So in abdominal examination, I need to see inspection to see whether she can any voluntary guardness or anything like that. I need to feel her tummy. I need to see whether any areas of tenderness, rigidity, or rebound tenderness, and also if I feel any mass, okay? I need also to examine her vaginally, like we do a bimanual examination, feel the uterus and see if there is any uterine tenderness, feel the adnexia using your bimanual examination as well through the lateral vaginal fornices and your other hand on her abdomen, and see if there is any adnexial masses, any adnexial tenderness. And after that, we move the cervix with your hand and see cervical motion tenderness. After you do the bimanual examination, you need to do a speculum examination just to have a look on the neck of the womb, if any abnormality or anything, and then we need to take the swabs. We need to take the high vaginal swab, we need to take the chlamydia and gonorrhea swabs. So all the swabs will be sent for the culture and sensitivity test. That's the examination needed. Then we need to do some investigations. First investigation we need to do is the urine. We need to take her urine sample. The first is urine pregnancy test. So this urine is important for urine pregnancy test and urine dipstick. Urine dipstick just to exclude any possibilities of UTI, because this presentation can be a kind of pyelonephritis and just mistaken for PID. Okay, and also if anything in her urine dipstick, we will send the urine for MSU or urine culture. Okay, So the swabs is part of the investigations we already done during the examination. Then we need to take blood sample from the patient. We need to check her full blood count, C-reactive protein, renal function, liver functions, lactate, and blood culture. That's only if we think her condition is severe, like her observations are highly in the red line, so we need to do the lactate and the blood culture at the same time. But if she's mild to moderate, no need to do lactate and the blood culture, and we will be like, sending only full blood count and C-reactive protein. So what are the differential diagnoses? Actually, the differential diagnosis can be anything, but because she has tender abdomen or painful abdomen and fever, it can be UTI, it can be acute appendicitis, it can be IBS, okay? If she has like rigidity, tenderness, rebound tenderness, it can be like differential diagnosis with ectopic pregnancy. It can be ovarian cyst accident, because we may, the fever can maybe present as a coincident finding, is not necessarily to be related to her pain abdominally. So we need to differentiate, to put a full differential diagnosis of all the three symptoms together. Okay. So the examiner will ask you, okay, so he will give you some finding from the examination, from the investigation. So you may have a high suspicion of PID. So what we are going to do we need to admit the patient, or do we need to treat her as an outpatient and give her the antibiotic regimens to take home? So that depends on how severe her condition is. Okay, so if her condition is mild to moderate, then we can give her the medication like an oral antibiotic regimen, and she can go home, and we will update her once we have the result of the swabs. However, if her condition is moderate to severe, then we need to keep her in the hospital, give the antibiotics through the IV line, and once she improves, then we continue the IV antibiotics for 24 hours after clinical improvement, and then shift to oral. Okay, so what are the criteria when it comes? Then we will decide that we need to admit the patient. As I told you earlier, that the temperature is one of the things that we may decide the patient to be kept in. So if her temperature exceeds 38 degrees, we need to keep her in the hospital. Is also if she has clinical signs of ovarian abscess. What does this mean? Like if you are doing your adnexial tenderness and you felt a mass, suggesting very tender mass and fluctuating, pulsating under your hands, so it's suggesting that she has an abscess, then we can't send her home. Okay, or if she's getting any signs of peritonitis, which are abdominal tenderness, rigidity, and rebound tenderness. These are the signs of peritonitis. We can't send her home. So if any of these signs are there, we need to keep the patient in, and we need to arrange for her an ultrasound scan. Why we need to arrange an ultrasound scan? First of all, we need to confirm the diagnosis. We need to confirm there is nothing else causing her symptoms. And also we need to exclude any tubo-ovarian abscess, any pelvic abscess, any ovarian cyst accident. Okay, so we need to do an ultrasound as an inpatient. Okay, so what are the treatment medication or the regimen? So there is a fixed treatment regimen for the PID, which can cover gonorrhea and chlamydia, which are the two common, the most common two types of PID. So if we are going to admit the patient, we need to give her ceftriaxone 2 grams IV every 24 hours. Okay, that's the first medicine. And we will add doxycycline 100 milligram, either oral or IV, twice daily. We prefer, since the patient is inpatient and she has IV line, we give all the antibiotics by IV. So ceftriaxone 2 grams every 24 hours and doxycycline 100 milligrams IV every 12 hours. And this will be continued until she gets clinical improvement. Usually, when we admit these patients, we'll repeat their bloods, like, after the antibiotic start. Like, if we start antibiotic today, we give 24 hours and then we repeat the bloods to see the clinical improvements in the white blood cells, clinical improvement in CRP, and if she has high lactate, we repeat it and see the difference. If she is having clinical improvement and laboratory improvement, then we will wait 24 hours after this improvement and shift her to oral. What are the oral medications? The oral medication is doxycycline and metronidazole. So doxycycline will be the same dose as IV, will be 100 milligram twice daily for 14 days. Metronidazole will be 400 milligram twice daily for 14 days as well. So in total will be 2 weeks of oral antibiotics. That's why I told you don't forget to ask about allergies. If the patient is having allergy to ceftriaxone, what we need to do, we can try clindamycin and gentamicin. However, if she has allergy, we need to speak to the microbiologist first and take his advice. Okay, that's if we are going to treat her as an inpatient. However, if she is having a coil fitted and after 24 hours we give her the IV antibiotic regimen, but she is not improving, what we need to do, we need to counsel her for taking the coil out. And because sometimes this coil may keep her resistant to antibiotics because of the infection. So if she is not improving with the antibiotics in 24 hours, we will take the coil out and continue the IV antibiotics and see how it goes. Okay, so that's in inpatient regimen. If you are going to treat the patient at home, like she comes today and you decided that she's having a mild symptoms and she can go home and take treatment home. So what we need to give her, so she's here now, so give her 1 shot of triaxone, 1 gram single dose intramuscular, and then we will give her the same oral regimen, which is doxycycline 100 milligram BD for 14 days, along with metronidazole 400 milligram per day for 14 days. Okay. So the examiner may tell you that why we need to start the antibiotic straight away. Do we need to wait until the culture results come and confirm that we have PID? Because sometimes she may not have any PID or any infection, and we are giving her long-term antibiotics with no benefit or no evidence that she has any infection. That's right. However, we need to start the antibiotics as soon as possible, because if we left it untreated and the patient came in 3 days with a positive culture, then we are at risk of severe complications that may already be built on. What are the complications? So these infection initially can spread inside the pelvis, causing inflammation in the tube, hydrosalpinx, biosalpinx, tube ovarian abscess, uh, pelvic abscess, pelvic adhesions. It will destroy completely the tubes, and also it causes many adhesions, including what we call Fitzhugh-Curtis syndrome, which is adhesions around the the liver, and it can also cause infertility on the long term run, and also it will increase the patient's risk to develop ectopic pregnancy. In some situations, these infections can go and spread through the bloodstream and causing septicemia and septic shock and end organ failure. So we don't need to wait, because we don't know where this infection is going to spread, and even if it just spread locally, it will have very, very harmful complication. So to avoid that, we will start the antibiotic regimen, and if just in case in 3 days time her culture is negative, we can call the patient, update her, and then we ask her to stop the medication, because there is no need, that she's not confirmed to have PID. However, if it came positive, then she's already received the correct and the right treatment. Okay, so in 3 days time, if the patient came with this result of culture, what we need to do? So this culture is showing gram-negative diplococci, as you can see, which is very characteristic for the gonococci or gonorrhea. Gonococci is the bacteria causing gonorrhea. So when the examiner show you this photo, will ask you what you need to do first, next. So we need to call the patient and explain to her that she has been exposed to an infection called gonorrhea, which is one of the sexually transmitted infection. But we need to reassure her that she has received the correct treatment so far, but she needs to avoid having sex. We need to advise her that even before having a positive culture, since we suspect that she has PID, we need to ask her not to have sex unless she confirms. So now we confirmed that she has a gonorrhea, so I will tell her that not to have any sex until she received a negative, or a proof or a confirmation of a cure from this infection for her and for her current partner. Okay, and not only her current partner, she needs to notify all of her previous partners in the last 3 to 6 months. Some of the patients may find it difficult, okay, because they may need to maintain their confidentiality. They can't, disclose this to someone else who is who was a previous partner. So anyway, as all of us know that any woman who is diagnosed with one sexually transmitted infection, we need to refer her to the sexual health clinic or the local GUM clinic. So since we are anyway going to refer her to the GUM clinic, we will tell her that if she is not able to notify her partners, we will tell her that we can help you in that the sexual health clinic can send some letters to your previous partners, just stating that they have been exposed to a sexually transmitted infection, and they will suggest them to go for checkup without mentioning the patient name or any details about her, so that will maintain her confidentiality. Okay, and we didn't stop at this point. We need to ask the patient to come in 2 weeks' time after completing her regimen of antibiotics to do what we call the test of cure. So after 2 weeks, so she will have the the oral treatment for 2 weeks. After the last dose, like, she has to come after, like, 72 hours from her last dose. We take the culture just to be sure that she has been totally cured from this infection for her and for her partner. And even though we need to advise her to use safe sex practice, use condom, even if she is using any other reliable contraception method, that's because she may be at risk of reinfection or developing any other sexually transmitted infection. So referral to the gum clinic has two benefits. First of all is to screen her for other sexually transmitted infection, and also tracing her partner. Okay, partners. Sometimes the patient may be pregnant and she's about to deliver, and then we discover that she has gonorrhea. What we need to do, we need to give her the antibiotic as soon as possible, and once she delivers her baby, we need to give him the antibiotics. What if this infection is asymptomatic and we don't know that the patient is having gonorrhea? Sometimes the babies may be born with some conjunctivitis because of the gonorrhea infection can infect their eyes and causing secretions. In that situation, we may take a swab from the secretions. If it came positive for gonorrhea, then we need to straight away give the baby ceftriaxone as soon as possible, because if we left it untreated, it can cause permanent loss of vision. Okay. So the last thing I want to tell you, whether there is any rule of surgical treatment in case of PID or no. Usually the treatment is medical, with antibiotics. However, in very rare situation, we may need surgical management. When the patient is having a pelvic abscess, which is increasing in size in spite of antibiotic, or is not regressing and the symptoms are not improving, especially fever, or if the patient is deteriorating and going into sepsis because of that abscess. So we need to drain this abscess first and increase her responsibility to the antibiotics. So either, it depends upon, like, where is the abscess, whether it is really localized or spread all over. Like, if it is just a pelvic abscess on top of the vaginal vault, we can drain it under ultrasound guidance or CT guidance. However, if it is like a large tube ovarian abscess, or, like, making a huge connections, we may need to do a laparoscopy if the patient condition allows. Okay, so that's all regarding the PID. Even if the patient has chlamydia, not a gonorrhea, she's receiving the treatment on the right way. So these antibiotics can cover both chlamydia and gonorrhea, because they are the most common type of PID infection. Okay, thank you.